Welcome to vpod.ai, where we take a deep dive into the information you need to feel well informed. Today, we're embarking on a really crucial deep dive into lung cancer. This is such a complex disease, and our understanding of it, diagnosis, treatment, patient support, is constantly evolving. Our mission today is to, well, cut through some of that complexity, navigate the latest insights and research, and give you a clear, concise, compelling overview of what really matters most right now. We've looked through medical guides, clinical trial results, patient resources, really trying to pull out the key nuggets for you. Before we dive in, though, just a quick word from our sponsor. This deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor for all things enterprise storage, backup, disaster recovery, hyper-converged setups like VMware, Hyper-V, Proxmox clusters, AI servers, even the SA365 turnkey security appliance, plus public and private cloud solutions. You can check them out at stonefly.com for more info.
And it's a great topic because the field is seeing some truly breathtaking advancements. What's particularly fascinating, I think, is how personalized and precise treatments are becoming now.
Absolutely. It's a major shift.
This deep dive should really highlight that.
Definitely. So let's start with the basics. What exactly is lung cancer?
Okay, so at its core, lung cancer starts when cells in the lungs just begin to grow out of control. Think about your lungs, these incredible sort of sponge-like organs in your chest. Their whole job is this vital exchange, bringing in oxygen, getting rid of carbon dioxide. They use this intricate network, bronchioles, alveoli. Cancer just disrupts that fundamental process.
And it's not just one single disease, right? There are different types.
That's right. It mainly breaks down into two main types.
Okay.
The most common one, making up maybe 80 to 85% of cases, is non-small cell lung cancer. We call it NSCLC.
NSCLC.
Yep.
Yeah. And are there key distinctions within that big group?
Yes, definitely. NSCLC itself has subtypes. The most common is adenocarcinoma. What's interesting here is that it's actually the most common type, even in people who've never smoked. We also see it a bit more in women and younger people. Then there's squamous cell carcinoma. This one's often linked quite strongly to a history of smoking and typically starts more in the central parts of the lungs and the airways.
Right.
And the third main one is large cell carcinoma. This type tends to grow and spread pretty quickly. It can be quite aggressive.
So that covers the 80-85%. What about the remaining 10-15%?
That's small cell lung cancer, or SCLC. And the really critical thing to understand about SCLC is its nature. It's aggressive. It tends to grow and spread much faster than NSCLC.
Much faster. Okay.
Exactly. And often by the time it's diagnosed, it's already spread beyond the lungs. Now, it does tend to respond well initially to things like chemo and radiation, but unfortunately, it frequently comes back.
And just to clarify something, if cancer starts somewhere else, say in the breast or colon, and then spreads to the lungs, we don't call that lung cancer, do we?
No, exactly right. That's metastatic cancer to the lung. You might hear about rarer lung tumors too, or even benign growths like hamartomas, but they're treated differently. And like you said, if breast cancer spreads to the lungs, it's still treated as breast cancer. The treatment is always based on the primary site where it started.
That's a really important distinction.
Mm-hmm.
Okay, let's talk symptoms. This is crucial for everyone listening. And it's where early detection can be such a hurdle, isn't it?
It really is. One of the biggest challenges with lung cancer is that most types don't cause noticeable symptoms until they've already spread somewhat.
So what should people be watching for? What are those common red flags?
Okay, key things to look out for. A cough that just won't go away or one that gets worse over time. Also, coughing up blood or maybe sputum that looks rust-colored.
Okay.
Chest pain is another big one, especially if it feels worse when you breathe deeply or cough or even laugh. Other things include hoarseness, losing weight without trying, loss of appetite, feeling short of breath, feeling really tired or weak, getting infections like bronchitis or pneumonia over and over again, or maybe a new wheeze that wasn't there before.
And then if the cancer spreads, the symptoms can change depending on where it goes.
Exactly. If it metastasizes, you might get bone pain, often in the back or hips. If it spreads to the brain, that can cause nervous system changes, things like headaches, maybe weakness or numbness in an arm or leg, dizziness, balance problems, even seizures.
Wow.
Spread to the liver can cause jaundice, that's the yellowing of the skin and eyes, and you might notice swollen lymph nodes, maybe in your neck or just above the collarbone.
Now, something I find fascinating is these unique symptom groups called syndromes. The cancer isn't necessarily in that part of the body, but it's causing trouble there anyway.
Yes, that's right. There are a few important ones. Horner syndrome is one. It's often linked to Pancoast tumors, which are cancers right at the top of the lung. The tumor presses on nerves going to the face and eye, so you might see a drooping eyelid, a smaller pupil on that side, and little or no sweating on that same side of the face. Severe shoulder pain often comes with it, too.
And then there's superior vena cava syndrome, or SVC syndrome. That sounds quite serious.
It can be very serious, yes. The superior vena cava is a large vein near the top right lung. It carries blood from your head and arms back to the heart. If a tumor presses on it, the blood backs up. This causes swelling usually in the face, neck, arms, upper chest. Sometimes the skin can look bluish red. It can also cause trouble breathing, headaches, dizziness, maybe even changes in consciousness. SBC syndrome is a medical emergency. It needs immediate attention.
Wow. Okay.
And beyond those, there are what we call paraneoplastic syndrome.
Paraneoplastic. Okay.
These are really interesting. They cause problems in distant parts of the body, even if the cancer hasn't spread there directly. It happens because the cancer cells might release hormone-like substances, or they trigger the immune system to mistakenly attack normal tissues. These are actually more common with SCLC.
So the cancer isn't physically there, but it's having effects elsewhere. That's wild. What kind of issues can these cause?
They can affect different systems. For example, the endocrine system, you might get SIADH syndrome of inappropriate antidiuretic hormone. Basically, the cancer makes the body hold on to too much water, which lowers salt levels in the blood.
Okay.
Or Cushing syndrome, where the cancer produces a substance leading to too much cortisol that can cause weight gain, easy bruising, weakness. Another one is hypercalcemia, high calcium levels in the blood. That can cause frequent urination, thirst, confusion, constipation.
And can they affect the nervous system too?
Yes, definitely. Sometimes the immune system gets confused and attacks parts of the nervous system. You can get things like Lambert-Eaton syndrome, which affects the connections between nerves and muscles, causing weakness, or paraneoplastic cerebellar degeneration, where the immune system attacks a part of the brain controlling balance and coordination. That causes major movement problems. There's also paraneoplastic limbic encephalitis, which affects areas of the brain involved in memory, emotion, and sleep.
That's quite a range of potential symptoms. The key message here, though, really seems to be, while lots of things can cause these symptoms, if you experience any of them, especially if they're new or just not going away, you must see a doctor promptly.
Absolutely. Don't delay. Early detection can make a massive difference in how effective treatment can be.
Couldn't agree more. Okay, so let's say someone goes to the doctor, tests are done, and unfortunately a diagnosis of lung cancer is made. What's the next critical step? Staging, right?
Yes, staging is absolutely essential. It tells us two main things: the size of the cancer and, crucially, how far it has spread. This information directly guides the treatment plan. It's like creating a map of the disease.
And how is staging determined?
It's based on a combination of things. The symptoms the person is having, detailed imaging tests, CT scans are very common, PET scans too, and, importantly, biopsies, getting actual tissue samples.
How does the staging system differ between the two main types?
For NSCLC, we use a number system, stages I through 4. Sometimes there are subdivisions like stage IIIA or IIB to get more specific. For SCLC, because it behaves differently, it's often described in broader terms: limited stage or extensive stage.
Limited versus expensive. What do those mean?
Limited stage generally means the cancer is confined to one side of the chest, the lung where it started, maybe nearby lymph nodes, all within an area that could potentially be treated with a single radiation field. Extensive stage means it's spread more widely, maybe to the other lung, to lymph nodes on the other side, or to distant organs like the liver, bones, or brain. Generally speaking, for both types, the higher the stage number, or if it's called extensive, the larger the tumor is and/or the more it has spread.
I know there's a more detailed system underlying this, the T&M system. Can you break that down?
Sure. T&M is used for both NSCLC and SCLC staging, providing a more precise description. T stands for tumor. This describes the size of the primary tumor, its exact location within the lung, and whether it's grown into nearby major structures like the chest wall or airways.
Okay, T for tumor. Then N.
N stands for nodes, meaning lymph nodes. It tells us if the cancer has spread to nearby lymph nodes, which are part of your immune system. Imaging can give clues, but often a biopsy of the nodes is the best way to know for sure. N0 means no lymph node spread. N1, N2, and N3 indicate spread to different lymph node locations, progressively further from the original tumor.
And finally, M.
M is for metastasis. This confirms whether the cancer has spread to distant parts of the body. Common sites include the other lung, brain, bones, liver, adrenal glands. N0 means no distant spread. M1 means it has spread.
Got it. T, N, M tumor, nodes, metastasis.
Exactly. Combining the T, N, and M findings gives us the overall stage.
So beyond the history and physical exam, what tools are used to gather all this T and M information?
A full diagnostic workup usually involves imaging like CT scans, often PT-CT scans, which can show active cancer cells anywhere in the body, sometimes a brain MRI to check for spread there, and blood tests. But as we mentioned, the absolute cornerstone for diagnosis and sometimes staging is the biopsy.
Getting that tissue sample seems key.
It is. Taking a small piece of tissue from the lung tumor itself, maybe a suspicious lymph node, or even a metastatic site, and looking at it under a microscope is what gives definitive proof of cancer. It also tells us the specific type of lung cancer.
How are biopsies done?
There are several ways. Bronchoscopy involves inserting a thin tube with a camera down the throat into the airways. Tools can be passed through it to take samples. Endoscopic ultrasound, EUS, or endobronchial ultrasound, EBUS, use ultrasound probes on the end of scopes to see lymph nodes through the walls of the esophagus or airways, allowing for guided needle biopsies. It's quite sophisticated. Sometimes mediastinoscopy is needed, which is a minor surgical procedure to look at and biopsy nodes in the chest between the lungs, or even a surgical biopsy of the lung tumor itself.
Is it possible for a biopsy to miss the cancer?
It is, unfortunately. Sometimes a needle biopsy might not get enough cells, or it might just miss the cancerous area, especially if the tumor is small or heterogeneous. A negative biopsy doesn't always 100% rule out cancer if there's still strong suspicion based on imaging or symptoms. Sometimes a repeat biopsy or a different type of biopsy might be needed. Generally, larger samples give more accurate results.
Okay, that makes sense. Let's shift gears now to being proactive. Screening and prevention. What are the current guidelines for lung cancer screening?
Right now, the U.S. Preventive Services Task Force, the USPSTF, recommends annual screening with a low-dose CT scan, or LDCT. But it's not for everyone. It's recommended for adults aged 50 to 80 who have at least a 20-pack year smoking history and who currently smoke or have quit within the last 15 years.
Can you quickly explain pack year?
Sure. 1 pack year means smoking an average of 1 pack of cigarettes. That's 20 cigarettes per day for 1 year. So smoking 1 pack a day for 20 years is 20 pack years. Smoking 2 packs a day for 10 years is also 20 pack years.
Got it. So 50 to 80 years old, 20-plus pack years, and current or recent former smoker.
That's the group. And the recommendation is to stop screening once someone hasn't smoked for 15 years, or if they develop a serious health problem that would make lung surgery risky or limit their life expectancy significantly. It's also really important that people have a conversation with their doctor about the potential benefits and risks of screening, things like false positives, anxiety, radiation exposure. It should be a shared decision.
And for people still smoking.
Smoking cessation support should absolutely be offered alongside screening. Quitting is still the most important thing.
Now, here's something I found really striking. While LDCT screening has been shown to reduce overall deaths from lung cancer, the picture's different for SCLC, isn't it?
That's a critical point, yes. For small cell lung cancer specifically, screening with LDCT has not been shown to reliably detect it at an earlier stage or improve survival outcomes. Even with screening programs, the majority of SCLC cases are still diagnosed at stage V, the extensive stage. It grows so fast that it often outpaces annual scans.
So if screening isn't the answer for SCLC, prevention becomes even more paramount.
Absolutely. The link between SCLC and tobacco is incredibly strong. Around 98% of SCLC cases occur in people who are current or former smokers. It's one of the strongest links between an environmental exposure and a specific cancer type. So preventing smoking in the first place and helping smokers quit are by far the most effective ways to reduce the burden of SCLC worldwide.
And quitting helps even after diagnosis.
Yes, significantly. Quitting smoking, even after being diagnosed with limited-stage SCLC, is associated with better survival and a lower risk of treatment complications or developing a second cancer. It's never too late to quit.
That's a powerful message. Let's talk treatment now. This is where things are really changing. I want to start with palliative care because I think there's a big misunderstanding about it. It's not just for the very end of life, is it?
Not at all. That's probably the biggest misconception. Palliative care is specialized medical care focused on providing relief from the symptoms and stress of a serious illness, like lung cancer. The main goal is to improve quality of life for both the patient and their family.
And where should it start?
Ideally, it should start early, right from the time of diagnosis, and continue alongside active cancer treatment like chemotherapy, radiation, or immunotherapy. It's not instead of curative treatment, it's in addition to it.
Okay, that's key. And I read some fascinating studies showing that early palliative care for lung cancer patients not only improves their quality of life and mood, but they actually tend to live longer.
That's absolutely right. Those studies were groundbreaking. Patients receiving early palliative care alongside standard oncology care reported better quality of life, less depression, and surprisingly, had longer median survival compared to those receiving standard care alone.
Why do you think that is?
While the palliative care team focuses intensely on managing symptoms, pain, shortness of breath, fatigue, nausea, anxiety, depression, better symptom control might allow patients to tolerate their cancer treatments better, stay more active, maintain better nutrition, all factors that can impact survival. Plus, it addresses the whole person, emotional, social, spiritual needs too.
So how does someone access palliative care?
You should ask your oncologist or primary doctor about it. Many hospitals and cancer centers have dedicated palliative care teams, doctors, nurses, social workers, chaplains. It can be provided in the hospital, in outpatient clinics, sometimes even at home. And importantly, most insurance plans, including Medicare and Medicaid, cover palliative care services.
So just to be crystal clear, palliative care is not the same as hospice care.
Correct. That's crucial. Palliative care is appropriate at any age and at any stage of a serious illness, whether it's potentially curable, chronic, or life-threatening. Hospice care is specifically for people nearing the end of life, typically with a prognosis of 6 months or less, when curative treatments are no longer being pursued. Palliative care principles like symptom management are definitely part of hospice, but palliative care itself can be given for years alongside active treatment.
Thanks for clearing that up. Now let's dive into the really exciting stuff, the new horizons, particularly in NSCLC treatment. We're seeing this huge shift towards therapies tailored to the specific genetic drivers of a patient's cancer, right? It's not one size fits all anymore.
Exactly. NSCLC treatment has been revolutionized by this concept. We expect over 226,000 new lung cancer cases in the U.S. in 2025, and NSCLC is the vast majority. Understanding the specific mutations driving an individual's tumor is now standard practice.
So let's talk about improving on old targets. EGFR inhibitors, for example. We've had those for a while, but resistance is a problem.
Yes, EGFR mutations are a common driver, especially in adenocarcinomas. We have several effective FDA-approved drugs targeting EGFR, but the cancer often finds ways to become resistant over time. So research is focused on overcoming that. For instance, there's a newer generation EGFR inhibitor called aumolertinib, approved in China. Recent trials combining it with chemotherapy as a first-line treatment showed a really impressive improvement in progression-free survival. Patients lived almost 10 months longer without their cancer growing compared to chemo alone. That's a significant gain.
10 months is huge.
It really is. And another approach uses antibody-drug conjugates, or ADCs. We mentioned these briefly before. Think of them like guided missiles. An ADC called SYS-60 targets EGFR. In early trials, it showed responses even in patients whose cancer had become resistant to other EGFR drugs. 9 out of 10 resistant patients responded in one small group. That's very promising.
And what about other established targets like ROS1?
ROS1 is another driver mutation. Challenges there include mutations that cause resistance, like the G2032R mutation, and also getting drugs into the brain to treat metastases. A new drug called JYP-0322 was specifically designed to overcome these issues. It crosses the blood-brain barrier effectively. Early results show good response rates overall, and importantly, a 43% response rate within the brain for patients with metastases there. That's a critical need being addressed.
Being able to target brain mets is a game changer. Now, what about targeting new drivers? We heard a lot about KRAS G12C a few years ago, but now KRAS G12D is getting attention.
Right. KRAS mutations are notoriously difficult to target. The approval of drugs for KRAS G12C was a major breakthrough, but KRAS G12D is actually the most common KRAS mutation across all human cancers, including lung cancer. There's a new drug called zoldonrasib that targets KRAS G12D in a novel way. It binds to the active form of the KRAS protein, which might help delay resistance. Early results in NSCLC patients with this mutation are encouraging, showing good tumor shrinkage and disease control with manageable side effects. Still early days, but definitely hopeful.
Tackling the most common KRAS mutation would be huge. And then there are strategies borrowed from other cancers, like targeting HR2.
Yes, exactly. HR2 is well known in breast cancer, and HR2 targeted drugs have been used there for over 2 decades. But specific HR2 mutations can also drive a small subset of lung cancers. It took until 2022 for the first HR2 targeted therapy to be approved specifically for lung cancer. Now, newer agents are showing even better results. Zongertinib, a novel small molecule A2 inhibitor, showed a remarkable 71% response rate in an early trial in HR2 mutated NSCLC, and notably with fewer of the typical side effects like rash and diarrhea seen with older drugs.
That's impressive.
And another one, SHR-1811, a HR2 targeted ADC, showed a 74.5% overall response rate in previously treated patients, with excellent 12-month survival rates reported so far. So we're really leveraging that knowledge from breast cancer now.
But it's not always straightforward progress. Sometimes promising avenues hit roadblocks, like the TIGIT pathway recently.
That's true. Research involves setbacks. TIGIT is an immune checkpoint, another potential target to help the immune system fight cancer. Hopes were very high for TIGIT inhibitors. However, a large phase 3 trial called Skyscraper-01, testing the TIGIT inhibitor tiragolumab combined with another immunotherapy drug, atezolizumab, in NSCLC, unfortunately did not show a statistically significant improvement in how long patients live without the cancer progressing or in overall survival.
So is that pathway a dead end?
Not necessarily. While this specific trial didn't meet its goals, researchers haven't given up. They're looking closely at the data, trying to see if maybe a specific subgroup of patients did benefit, or if different combinations or approaches might work. Sometimes it takes refinement to find where a new therapy fits best. It highlights the complexity of immunotherapy.
Right. Okay, let's pivot now to SCLC management. As you said, it's a tougher foe. What are the main goals when treating SCLC that hasn't spread widely yet?
For non-metastatic SCLC, so limited stage, the main goals are achieving durable control of the cancer within the chest and reducing the chances of it spreading elsewhere, particularly the brain. With the right combination of treatments, usually chemotherapy and radiation given together, we can achieve 5-year survival rates in the range of 25–30%, which, considering how aggressive SCLC is actually quite significant progress compared to decades ago.
What about the very small number of patients found at a truly early stage, like stage I?
That's a rare situation for SCLC, maybe only 5% of cases. Management here is a bit controversial because there aren't large trials to guide us definitively. Options might include surgery followed by chemotherapy, or sometimes focused radiation therapy like stereotactic radiotherapy. The role of prophylactic cranial irradiation, PCI, preventative brain radiation, is less clear in this very early group.
Okay, but most non-metastatic SCLC involves lymph nodes in the chest, the mediastinal and hilar nodes. That's more locally advanced.
Yes, that's the more typical limited stage presentation. The standard of care here, for patients fit enough, is concurrent chemoradiotherapy. That means giving chemotherapy, usually cisplatin and etoposide, at the same time as radiation therapy to the chest. Often, the radiation is given twice a day in smaller doses over about 3 weeks. This approach gives the best chance for cure, leading to that roughly 30% 5-year survival. Modern radiation techniques have also really helped reduce side effects like severe lung or esophagus inflammation compared to older methods.
And PCI, the brain radiation, that comes in after this.
Yes. For most limited-stage patients whose cancer responds well to the initial chemoradiation, PCI is a standard recommendation. SCLC has a very high tendency to spread to the brain. PCI significantly cuts down that risk and has been shown to improve overall survival in this group.
Now, let's talk about metastatic or extensive stage SCLC. This is where its aggressive nature is really apparent. What was the standard for decades?
For about 30 years, the first-line treatment was chemotherapy, a platinum drug, cisplatin or carboplatin, combined with etoposide. It works well initially for many patients shrinking tumors, but the responses often don't last long.
But there's been a major shift recently with immunotherapy, right?
Absolutely. This has been the biggest advance in first-line extensive-stage SCLC in decades. Adding an immunotherapy drug, specifically an anti-PD-L1 antibody like atezolizumab or durvalumab, to the standard platinum etoposide chemotherapy, and then continuing the immunotherapy alone as maintenance treatment, has shown a statistically significant improvement in both progression-free survival and, importantly, overall survival.
How big an improvement?
What's really striking is that this chemo-immunotherapy approach has roughly doubled the 2-year survival rate for these patients. It went from about 11% with chemo alone to around 22% with chemo-immunotherapy.
Yeah, doubled is significant.
It is. It means there's a subset of patients, maybe around 1 in 5, who are now achieving more durable long-term benefit, which was almost unheard of before. Even though most patients still eventually progress, this is a major step forward.
And interestingly, unlike in NSCLC, where PD-L1 testing helps guide immunotherapy use, it doesn't seem to predict benefit here.
That's right. So far, we haven't found a reliable biomarker, including PD-L1 expression, to tell us which SCLC patients will benefit most from adding immunotherapy. So it's generally offered to most eligible patients with extensive stage disease.
What about when the cancer comes back or progresses after that first-line treatment? Are there better options now?
Yes, thankfully. For many years, there were very few effective second-line options. Topotecan was the standard, but responses were limited. Recently, the FDA granted accelerated approval to a drug called lurbinectedin for second-line SCLC. In its key trial, it showed a response rate of about 35%, offering a needed alternative. And for third-line treatment, 2 other immunotherapy drugs, nivolumab and pembrolizumab, which target PD-1, are approved based on showing some durable responses in a small fraction of patients. So the landscape is slowly improving, even for relapsed disease.
And radiation still has a role in advanced disease.
Yes, primarily for palliation-relieving symptoms. Radiation can be very effective at easing pain from bone metastases, or treating brain metastases, or relieving airway obstruction. The role of PCI in extensive stage disease after chemo-immunotherapy is still debated. Some studies suggested a benefit, others didn't. Especially with routine brain MRI surveillance now available, it's an area of ongoing research.
So with SCLC being so prone to relapse, what does follow-up look like? And what about other health issues?
Follow-up needs to be vigilant. The risk of relapse is high, over 75% for limited stage and over 90% for extensive stage within about 2 years. So regular CT scans to monitor the chest and abdomen and often brain MRIs are standard. Beyond recurrence, these patients, mostly former or current heavy smokers, often have significant other health problems, cardiovascular disease, COPD, emphysema. Managing these comorbidities is crucial for overall well-being and survival. It really highlights the need for a multidisciplinary team approach involving not just oncologists, but pulmonologists, cardiologists, primary care physicians, palliative care specialists to manage everything comprehensively. Better symptom control leads to better quality of life and potentially better outcomes.
And the smoking cessation message remains critical throughout.
Absolutely critical. Continuing to smoke after an SCLC diagnosis is strongly linked with worse survival, higher risk of treatment side effects, and increased risk of developing a second smoking-related cancer. Quitting provides benefits at any stage.
Let's transition to thinking about quality of life and the patient perspective more broadly, which you touched on. Modern cancer care really aims for personalized care, doesn't it?
It really does, or at least it should. It's about tailoring the treatment plan, not just to the cancer's biology, but also to the individual patient's values, preferences, goals, and overall health status. Open, honest communication from the start about prognosis, the potential benefits and burdens of different treatments, and the role of supportive care like palliative care is so important. It should be a team effort involving the patient, their family, and the whole healthcare team.
Balancing the treatment against its impact on daily life seems key.
Exactly. Patients need to be fully informed about potential side effects, both short-term, like nausea or fatigue, and potential long-term ones, like neuropathy or cognitive changes. How will treatment affect their ability to work, to engage in hobbies, to spend quality time with loved ones? Especially for patients with advanced cancer, where cure might not be realistic, the focus often shifts towards ensuring the benefits of any treatment clearly outweigh the toxicity and the time spent receiving it. It's about maximizing good quality time.
We heard that incredibly hopeful story from Nina Beatty, the SCLC super responder to immunotherapy. While her experience is rare, it really underscores that durable responses can happen, even in SCLC.
Her story is amazing, and it provides immense hope. It also fuels research, right? Scientists are actively studying patients like her, these exceptional responders, trying to understand why their immune systems reacted so effectively. What's different about their tumors or their immune cells? Unlocking those secrets could help make immunotherapy work for more people.
Definitely. And on the topic of quality of life, you mentioned concerns about neurotoxicity from PCI, the brain radiation.
Yes, that's an important consideration. While PCI reduces brain metastases, it can unfortunately cause cognitive side effects for some patients, memory problems, difficulty concentrating. It's complex because other factors can contribute too, like the effects of chemotherapy, underlying vascular issues from smoking, anxiety, even the cancer itself. But researchers are actively working on ways to mitigate this. Clinical trials are looking at techniques like hippocampus-sparing PCI, where radiation beams are shaped to avoid the hippocampus, a brain area crucial for memory.
That sounds promising.
Other trials are comparing routine PCI versus just doing regular brain MRI surveillance and only treating metastases if and when they appear. The goal is to find the best balance between controlling brain disease and preserving cognitive function and quality of life.
Looking ahead then, despite the challenges, particularly with SCLC, the future seems to hold real promise, driven by deeper understanding and new technologies.
I think so. We've made huge strides in understanding SCLC biology. Developing better lab models like patient-derived xenografts or genetically engineered mouse models that truly reflect the human disease has been key. Analyzing human tumors with advanced sequencing has revealed distinct molecular subtypes of SCLC, which might respond differently to treatments. And as we discussed, technological advances in imaging and how we deliver radiation have already improved survival for localized disease while making treatment safer and more tolerable.
And the arrival of chemo-immunotherapy for metastatic SCLC, while not a cure-all, was a landmark.
It really was. It proved the principle that SCLC can be recognized and targeted by the immune system, specifically by cytotoxic T cells. Achieving durable benefit for even a subset of patients was a major conceptual leap forward for the field. But, and it's a big but, SCLC still remains lethal for the vast majority of patients, and we still lack effective screening or early detection strategies specifically for SCLC. That remains a huge unmet need.
So the challenge now is figuring out why only that minority benefits from current immunotherapy and how to activate an effective immune response in the rest.
That's the central question driving a lot of current research. Why are most SCLC tumors cold or non-responsive to immunotherapy? How can we turn them hot? Future research is focusing on things like single-cell analysis to really understand the diversity of cells within a tumor and how they interact. Exploring combination strategies, maybe pairing immunotherapy with drugs that target DNA damage repair, or epigenetic regulators that control gene activity, or drugs that target specific resistance pathways.
And for earlier stage disease.
For limited stage SCLC, trials are underway looking at adding immunotherapy, checkpoint inhibitors, to the standard chemoradiation backbone. We're also exploring novel agents targeting specific vulnerabilities, like proteins involved in DNA damage response or epigenetic modifications, often based on the molecular subtype. Another exciting area is the development of highly sensitive biomarkers, like measuring circulating tumor DNA, ctDNA, in the blood. This could potentially help us detect relapse earlier, monitor treatment response non-invasively, and maybe even identify patients who are likely cured versus those who might need additional consolidation therapy after initial treatment.
It really feels like we're on the cusp of more significant changes. This accelerating pace of research, the technology, the deeper understanding of the biology. How do you see this reshaping personalized cancer care moving forward, maybe even beyond lung cancer?
I think it's a fundamental shift. We're moving away from treating lung cancer or even SCLC as single entities towards understanding each patient's cancer at a molecular level and matching them with the most effective therapies, potentially combinations, while also considering their individual needs and quality of life. This integration of deep biological understanding, advanced diagnostics like liquid biopsies, novel therapeutics like ADCs and targeted agents, and smarter use of existing tools like radiation and immunotherapy, it's creating a much more dynamic and tailored approach. It really holds immense promise for improving outcomes across many complex diseases, not just cancer. It's a very exciting time in medicine.
It truly is. Wow, that was quite a deep dive into the incredibly complex and rapidly evolving world of lung cancer. We covered a lot from the basic types and symptoms to the latest treatment breakthroughs and the absolutely vital role of things like palliative care and the patient perspective. Before we wrap up, just one more mention of our sponsor, Stonefly. They're currently offering a 100 terabyte immutable and air-gapped SSO NAS solution for just $8,995. Really impressive offer. You can find out more at stonefly.com. Thank you so much for joining us on this deep dive today. Until next time, keep exploring, keep learning.